Good morning, everyone. Thank you for joining us. This is our final CME for the year. And before we introduce the speaker, I just want to remind everyone that the CMEs for the year are ready. There are 13 CME certificates that are ready. So if you have done the assessment throughout the year, please remember to download your certificates. And please remember to type your questions in the chat. So this morning's speaker, Dr. Deshawn Saunders Ferguson. Dr. Deshawn Saunders is a pediatric consultant employed at the Princess Margaret and Doctors Hospital. She completed her undergraduate degree at Arcadia University and her medical degree at the University of the West Indies. She completed her pediatric residency with the Bahamas-Jamaica Partnership. She feels that the foundation for a healthy life is established in childhood, which is what makes pediatric medicine so special. To be an advocate for children, to learn from them while teaching and empowering families is an amazing opportunity. She believes that promoting healthy development from infancy to adulthood or adolescence requires collaboration with patients, families, and the community. She loves the field of behavior and development, and in her spare time, she volunteers with the autistic community in the Bahamas, where she serves as a board member for REACH, a nonprofit NGO that caters to the needs of developmentally challenged children. She's a jewelry designer on the weekends and loves to travel and is married with three children. So let's welcome Dr. Deshawn Saunders Ferguson. Thank you, Dr. Ferguson.
Good morning. Can you hear me and see me?
Yes, we can. Go ahead.
All right, so good morning. Thank you to the CME department and the Department of Pediatrics for allowing us to present pediatric multisystem inflammatory syndrome in the COVID-19 era. I have no financial disclosures or conflict of interest related to the CME. Since a cluster of pneumonia cases arising from unknown causes was first reported in Wuhan, China in December 2019, the COVID-19 pandemic caused by severe acute respiratory syndrome coronavirus, SARS, has rapidly spread worldwide at an alarming rate. On the 11th of March 2020, the World Health Organization declared a global pandemic. 4 days later, the Bahamas declared its first case on March 15th. Since that time, globally, there has been 67.9 million reported cases with 1.5 million deaths since the pandemic began. In the past week, cases of COVID-19 have remained at 4 million weekly, with new deaths at over 69,000. National statistics from countries in Asia, Europe, and North America show that children and adolescents make up a small proportion, accounting for approximately 2.1 to 7.8% of confirmed COVID-19 cases. However, because of asymptomatic infections in younger persons, the underdiagnosis of clinically silent or mild cases, typically occurring in young persons, may have been missed. In addition, availability and targeted strategies of current testing methods are limited in the pediatric population. According to the Royal College of Pediatrics and Child Health, COVID-19 was said to be non-fatal in the pediatric population. Since that time, however, 8 months later now, the US has now seen over 1.3 million children testing positive for COVID-19. This represents 12% of all cases in the US. And though majority of cases remain mild, as of late April 2020, a new and potentially life-threatening childhood disease emerged as a new entity of COVID-19 in children and adolescents. On April 7th, 2020, Jones and colleagues first reported a case of a 6-month-old infant in the USA. This infant presented with persistent fever and minor respiratory symptoms. He was diagnosed with Kawasaki disease, but was also found to have a positive RT-PCR result for SARS coronavirus. On April 26, 2020, clinicians now in the UK also recognized an increased report of previously healthy children presenting with severe inflammatory syndrome with Kawasaki disease-like features. 2 weeks later, the CDC issued an urgent health advisory that an associated multisystem inflammatory condition seemed to develop after infection, rather than during the acute stages of COVID-19 in children and adolescents. In the UK, this was now called Pediatric Multisystem Inflammatory Syndrome, temporarily associated with COVID-19. In the US, it was called Multisystem Inflammatory Syndrome in children. For the purpose of this presentation this morning, we will use these terms interchangeably. So if we were to look at this diagram, this actually shows some of the features of Kawasaki disease. In clinics all over Europe, North America, Asian, and Latin America, children began presenting. This new inflammatory syndrome shared many features common to other pediatric inflammatory conditions and cases, presenting with features of Kawasaki disease, shock, and toxic shock-like syndrome. In this new emerging challenge, children now presented specifically with high fever, rash, conjunctivitis, peripheral edema, and gastrointestinal symptoms, with some presenting even in shock and multi-organ failure. Some of these children required intensive care, sometimes affecting the coronaries. If we were to look at this timeline for the evolution of multi-system inflammatory syndrome, it began in early March in the UK with the first 37 cases from 8 hospitals in London, reporting children who were admitted with circulatory shock and hyperinflammatory state. Starting on the 4th of May, the New York City Health Department reported 85 cases of children and adolescents presenting to hospital with 3 deaths and 2 under investigation. A week later, France and Italy now reported 125 suspected cases, with 65 being considered for pediatric multi-inflammatory syndrome, and an additional having probable links to COVID-19. The pediatricians in the Bahamas went on Amber Alert. In the month of September, during the second surge, the Bahamas began having increasing cases of confirmed COVID-19 patients in the younger population. Statistics reveal that 130 children and adolescents below the age of 19 had tested positive with COVID-19 with mild to moderately severe symptoms. Over the last 3 months, the Department of Pediatrics has had 10 admissions related to COVID-19. These children range in ages from as young as 28 days to the maximum age of 12. The patients highlighted in yellow, so we have 2 on this page, and the 3rd on this page. For the purpose of this presentation today, we will focus on these 3 cases. So starting with case 1, on the 14th of September, a previously healthy 15-month-old toddler was airlifted from Managua with a history of fever, rash, and diarrhea by 3 days. His father and grandfather had had positive nasopharyngeal swab PCRs for SARS coronavirus 2 weeks before presentation. On his arrival, he was ill and toxic looking. He was in moderate respiratory distress, breathing at a respiratory rate of 56 breaths per minute. He was febrile at 102 degrees Fahrenheit and was hypotensive with a blood pressure of 61/28. Additional examination findings revealed bilateral crackles, conjunctival involvement, and an erythematous rash. Empiric antibiotics and fluid resuscitation was started. Blood tests were taken, and these revealed elevated inflammatory markers and hepatic dysfunction. A nasopharyngeal PCR for SARS coronavirus was taken on this patient, and that resulted positive. He was assessed as multisystem inflammatory syndrome in children and was treated with IV fluids, antibiotics, intravenous immunoglobulin, antithrombotic prophylaxis, and steroids. This patient never required inotropic support and remained hospitalized for 8 days and was discharged home with his mother for further follow-up. In our second case presentation, we had an 8-year-old female, and she presented 3 weeks later after our first patient. She was also noted to be febrile, with a rash, and presented with weakness and vomiting. On admission, her temperature was 104 degrees Fahrenheit. She was pale, she was tachycardic, tachypnic, and had a predominantly systolic hypotension with a blood pressure at 71/42. Blood and urine cultures were taken, and empiric antibiotics and fluid resuscitation was started. However, due to maintained tachycardia and hypotension, despite volume resuscitation, necessitated the use of inotropes, commencing with dopamine and eventual addition of dobutamine and eventually epinephrine for blood pressure support. Our third case was a 10-year-old male who presented once again 2 weeks later, and he was a previously healthy male, and he presented with a 4-day history of fever, headache, rash, weakness, and vomiting. This is our x-ray for our second patient. And if you were to look at the first x-ray, as you can see, it showed bilateral pulmonary infiltrates, suggestive of a COVID pneumonia. This patient was admitted and treated. And when we repeated her x-ray, 48 hours later, she was actually noted to have an increase in cardiac silhouette and features suggestive of congestive cardiac failure. And this patient was started on Lasix. This patient remained hospitalized for 17 days and was eventually discharged home after treatment. Our third case was a 10-year-old previously healthy male who presented with a 4-day history of headache, fever, diarrhea, vomiting, and rash. On presentation to the ER, he was febrile up to 103.8 degrees Fahrenheit. He was tachycardic at 135 beats per minute and hypotensive with a systolic blood pressure of 81. Blood, urine, and laboratory tests were performed. Empiric antibiotic and fluid resuscitation was started, and his blood test revealed elevations in inflammatory markers and significant troponin levels. In this patient also, due to maintained tachycardia and hypotension, despite volume resuscitation, he was commenced on inotropic support. Interestingly, in this case, his nasopharyngeal PCR swab for SARS coronavirus was negative, but his COVID antibodies were positive. His echocardiogram revealed a decreased left ventricular systolic dysfunction with an ejection fraction of 45%. This patient also had a small pericardial effusion, moderate mitral and tricuspid regurgitation. And if you were to look closely, he had a 5 millimeter saccular dilation of the right proximal artery and a left coronary and a left anterior descending 5 millimeter saccular aneurysm. He was treated with intravenous immunoglobulin, dexamethasone, and antithrombotic prophylaxis. A repeat echo 6 days later showed improvement in his left ventricular contractility and improvement in his ejection fraction with mild mitral and tricuspid insufficiency. This patient remained hospitalized by 10 days and was discharged home on aspirin, steroids, and for cardiology follow-up. So we in the Bahamas reported our first 3 cases. The case definition for multisystem inflammatory syndrome varies depending on the country and region. As we know, coronavirus is still evolving, and an internationally accepted case definition for multisystem inflammatory syndrome is still evolving. The Royal College of Pediatrics and Child Health referred to this acute condition as pediatric multisystem inflammatory syndrome temporarily associated with COVID-19. As more cases arose globally, the illness was then labeled by the United States as multisystem inflammatory syndrome in children, and this was labeled both by the Center for Disease Control and Prevention and the World Health Organization. When we look at our three case definitions, they, however, have a common principle. These common principles include 1, pediatric age, 2, persistence of fever, 3, presence of laboratory markers of inflammation, 4, manifestation of signs or symptoms of organ dysfunction lacking an alternative diagnosis, and 5, temporal relation to COVID-19 infection, or 6, some exposure. When we look closer at our guidelines, starting with the Royal College of Pediatrics and Child Health, their case definition involves any child with persistent fever, inflammation, evidence of single or multi-organ dysfunction, including shock, abdominal pain, vomiting, diarrhea, neurological presentations, including confusion, headache, and syncope. These patients may present with respiratory symptoms, but from studies and investigations, it shows that respiratory symptoms such as cough and sore throat are usually mild. In addition to these findings, the Royal College of Pediatrics also includes the criteria for Kawasaki disease in their case definition. And these patients may also present with lymphadenopathy, mucous membrane changes, rash, conjunctivitis, and edema to the hands and feet. While this case study represents that they may have a temporal association with COVID-19, the case definition for the Royal College of Pediatrics does not require proof of infection or exposure to meet their case definition. When we look at the CDC case definition, the difference is that they specify an age. So in the CDC, multisystem inflammatory syndrome in children is any individual less than the age of 21 with a presentation of fever. In this case definition, the fever should be greater than 24 hours and there is no time limit. In addition, there should be no alternative plausible diagnosis for the cause of fever. And in addition, this patient should have a positive current or recent SARS coronavirus infection, either confirmed by RT-PCR, serology, or antigen testing. If this is not possible, then if there is a positive exposure to a suspected or confirmed COVID-19 case within 4 weeks prior to symptom onset, this would then meet their case definition. When we look at our third case definition, which was produced by the World Health Organization, their age is for any child between the age of 0 and 19. And the difference with their criteria is that the child has had to have had fever for at least 3 days. In addition, this child must also have the presence of any 2 of the following. And these can include rash or bilateral conjunctivitis, similar to presentations of Kawasaki, or hypertension or shock, or features of myocardial dysfunction, or some presentation of gastrointestinal problems, or changes in laboratory findings, including increase in inflammatory markers, such as your ESR, CRP, or evidence of coagulopathy. They also indicate that there should be no other obvious microbial cause of inflammation, such as sepsis, or staphylococcal or streptococcal shock syndrome. In this case definition, for the World Health Organization, there should be evidence of COVID-19 either through RT-PCR testing, antigen testing, or this patient should tested positive for serology. In addition, if there was some exposure to this patient for COVID-19, this would meet their criteria. Now, one of the initial challenges faced by pediatricians worldwide was being able to differentiate patients with multisystem inflammatory syndrome for those presenting with Kawasaki disease or toxic shock syndrome. Kawasaki disease, as we know, is defined by the American Heart Association as a vasculitis, and this typically presents with high fever and acute mucocutaneous inflammation in children less than 5 years of age. What we discovered in terms of patients with multisystem inflammatory syndrome was that they present with 3 different types. The first presentation can be Kawasaki-like, and in this presentation, they have typical Kawasaki disease presentations with 4 out of 5 of the principal features, such as erythema, bilateral bulbar conjunctival injection without exudates, rash, erythema, edema of the hands or feet, presence of periungual desquamation, and this usually occurs about 2 weeks after presentation, and cervical lymphadenopathy. In the second type, patients were noted to have either incomplete Kawasaki disease, and so in this case, patients did not necessarily fulfill the typical Kawasaki disease criteria, but had at least 2 or 3 principal clinical features or a positive echocardiogram showing some valvular dysfunction or some coronary dilation or some heart abnormality. In the third type, in terms of presentation, are patients that would present in shock, which happens in 3 of our patients. These are patients who present and require at least a 20 ml per kg fluid bolus at the time of admission. Overlap has been observed between the diagnostic criteria for Kawasaki disease shock syndrome, and the newly emerged multisystem inflammatory syndrome. Although Kawasaki is typically a self-limiting condition, some children may have severe complications, including coronary artery aneurysms, myocardial dysfunction, and thrombotic events. And this is also being seen in multisystem inflammatory syndrome. Now, when we look at studies worldwide, the presentation showed that all patients, 100% of them, all presented with fever for at least 3 to 4 days. 89% of these patients had some type of bulbar conjunctivitis. 54% had red and cracked lips. 60% presented with cervical lymphadenopathy. 57% presented with skin rash, and 17% had some form of coronary dilation, and 8% of our patients presented with pericarditis. Now, as we're aware, the pathophysiology of this syndrome still remains unclear, because as we all know, COVID-19 continues to evolve. In adults with severe COVID-19, a late or hyperinflammatory state has been described, associated with massive pro-inflammatory response, also known as the cytokine storm. This is said to be characterized by high levels of inflammatory cytokines, such as interleukin-6, for example. This cytokine storm is thought to lead to an immune response, uncontrolled, and then leads to macrophage activation syndrome that produces in adults acute respiratory distress syndrome, and in our pediatric population, multi-organ dysfunction. Many authors also suggest that multisystem inflammatory syndrome is a delayed immune phenomenon associated with late phase or hyperinflammatory after asymptomatic or symptomatic SARS coronavirus infection. Studies from the UK, France, and the US indicated that children were presenting 4 weeks after COVID surges. This showed that previous rather than a current infection with SARS coronavirus was occurring. Only 1/3 of reported multisystem inflammatory syndrome cases are positive by RT-PCR for SARS coronavirus, whereas most cases are positive with an antibody test. So this indicates that these children may have been exposed to the coronavirus at least 3 to 4 weeks prior to presentation, and their acute presentation with MIS was actually as a result of a past infection. So this inflammatory syndrome is not mediated by direct viral invasion, but actually coincides with the development of an acquired immune response to SARS coronavirus. Antibodies to SARS coronavirus may accentuate the disease through antibody-dependent enhancement of viral entry and then amplification of viral replication, as observed in other disease entities such as dengue, or by triggering a host inflammatory response through the formation of immune complexes through direct anti-tissue antibody activation or cellular activation, or both. The pathogenesis of COVID-19 is still being studied. And our presentation actually has studies released as recent as 7 days ago. So as we know, this is continuously evolving. Evidence has also shown a dysregulated innate immune response and a subsequent cytokine storm and endothelial damage, which may play a role in the clinical manifestation of severe COVID-19. Genomic studies have also suggested that the release of spike viral proteins may be associated with the increased amplification of the hyperinflammatory response in pediatric patients. A study reveals that 45% of 440 children who presented with multisystem inflammatory syndrome through July 29, 2020, initially had a negative PCR and a positive SARS coronavirus antibody test result. So when we were to look at this slide, it shows you that in stages of the early infection, the severity of illness in the pediatric population may have been mild. However, in the adult population, the severity of illness is usually early in the infection. In stage 2 of the adult infection, it usually affects the pulmonary phase, but in stage 3, this is when our patients with multisystem inflammatory syndrome would present. And this is thought to have been because of a hyperinflammatory response phase. So this concludes that multisystem inflammatory syndrome is obviously likely a post-infectious process. The inflammatory disorders triggered by SARS coronavirus can also result in coronary aneurysms in the pediatric population. And this is also familiar or actually seen in some patients that present with Kawasaki. This finding suggests that this virus might be acting as the immune trigger and causing a similar immune-mediated injury to the heart and coronary arteries as the one seen in Kawasaki disease. As we are aware, immune complexes have been well documented in Kawasaki disease and might mediate vascular injury action by activation of inflammatory responses through the Fc gamma receptor or through complement activation. The possible mechanisms for an acquired immune response to accentuate SARS coronavirus 2 may include, like with Kawasaki, antibody or T-cell recognition of self-antigens resulting in autoantibodies, antibody or T-cell recognition of viral antigens expressed on infected cells, or the formation of immune complexes which activate inflammation, or some viral antigen sequence which activates the host immune cell. When we look at this graph, it shows the time course of multisystem inflammatory syndrome in our patients who were PCR positive. In adults, as we know, severe COVID-19 typically presents during the second week of illness, a timing coinciding with declining viral loads and increasing markers of inflammation. However, if we were to look at this graph, the blue line represents positive cases for SARS coronavirus, both in adults and children. But when we were to look at the red line, this shows cases that presented with multisystem inflammatory syndrome in children. And if we were to observe, this was actually taken from Public Health in England statistics, and their data revealed that around April 16th, and if we were to look at April 16 here, this actually occurred 4 weeks after the substantial increase in COVID-19 cases in that region. A review published in the Lancet Journal reports that multisystem inflammatory syndrome typically manifests 3 to 4 weeks after SARS coronavirus infection. This may explain why many children had positive antibodies to SARS coronavirus, but negative RT-PCR at the time of multisystem inflammatory syndrome evaluation. This review also noted that there was a higher rate of multisystem inflammatory syndrome in the African American, Caribbean, and Hispanic population, representing greater than 70%. There were not significant cases noted in the Asian population. A startling observation was that most cases presented with obesity, and that 50% of the patients that were diagnosed with multisystem inflammatory syndrome were obese. Studies are thought to think that the accumulation of inflammatory cells in adipose tissue, fat tissue associated with cytokines may be pro-inflammatory, resulting in increasing of SARS coronavirus binding receptors, as a result, causing a worsening presentation. The predominance of cardiac manifestations in children was also striking. Initial echocardiograms that were normal, a few days later showed depressed ejection fraction or dilation or aneurysm of the coronary arteries. When we were to look at cardiac findings in multisystem inflammatory syndrome, some of the findings included left ventricular dysfunction, coronary artery dilation or coronary artery aneurysm, electrical conduction abnormalities, valvular dysfunction, and pericardial infusion, even though these were less frequently described in the literature. Among the initial descriptions of multisystem inflammatory syndrome, left ventricular dysfunction was present in 20 to 55% of the cases, and coronary artery dilation or coronary artery aneurysms occurred in 20%. As we know, our case 3 of our patients actually had these findings. What are some of the risk factors that were revealed from studies for patients with multisystem inflammatory syndrome? It was noted that patients that presented less than 1 year of age presented severely ill. As we indicated earlier, obesity may also be a significant role in increasing the risk factor for multisystem inflammatory syndrome, and also the presence of comorbid illnesses such as asthma, chronic lung disease, cardiac or congenital heart disease, sickle cell disease, and immunosuppression. Multisystem inflammatory syndrome, as we know, evolves and presents with multi-organ dysfunction. And if we were to look at this diagram, as we can see, it can affect all organ systems. Studies have revealed that the gastrointestinal symptom presents with almost 80% of findings. So these patients may present with abdominal pain, nausea, vomiting, diarrhea, or hepatic dysfunction. Skin findings were noted to be seen in 62% of patients with rash, swollen hands or feet. There was also significant mucocutaneous involvement in 61% of the patients presenting with conjunctivitis, mucosal changes, or cracked lips. Other system involvements included neurological, musculoskeletal, and as indicated before, respiratory symptoms only made 20 to 27% of symptoms presenting with cough, congestion, sore throat, shortness of breath, or wheezing. A study published in the New England Journal of Medicine involved targeted surveillance of multisystem inflammatory syndrome from March 15 to May 20th, 2020, in the pediatric health centers across the United States. Multisystem inflammatory syndrome in children associated with SARS-CoV-2 virus led to serious and life-threatening illnesses in previously healthy children and adolescents, with more than 80% of these children requiring ICU care, 48% of these children requiring vasopressor support, and 40% presenting with Kawasaki-like symptoms. According to the CDC, in the US, as of December 4th, they reported a total of 1,288 total cases of multisystem inflammatory syndrome in children. This was reported from 44 states, and at this present time, additional cases are under investigation. In the US, they've had 23 total deaths, meeting the multisystem inflammatory syndrome case definition. They've noted that the average age is 8 years old and that more than 75% of the reported cases are once again noted in the Hispanic or Latino population or Black and non-Hispanic. The US data reveals that 99% of these patients tested positive for SARS coronavirus, either through antigen testing or through PCR. The UK published a study that reveals that 78 cases of patients were admitted to the pediatric intensive care in the UK. This study was a multi-center observational study, and it looked at patients less than the age of 18 who were admitted. And this study was over a 40-day period from April 1st to May 10th. Patients who fulfilled the criteria for multisystem inflammatory syndrome were noted to also, once again, and even in the UK, the ethnic minority made up 61% of cases. The median age in their study was noted to be 11 years compared to the US, which was 8 years. And 100% of these patients presented with fever, and 68 or 87% of their patients also presented in shock, and they also presented with similar findings of abdominal pain, vomiting, and diarrhea as common presenting features. This study was actually published just 7 days ago in the New England Journal of Medicine, and this study actually focused on cardiovascular complications in COVID-19, multisystem inflammatory syndrome in children. This actually revealed that COVID-19 multisystem inflammatory shares significant clinical features with that of Kawasaki disease, Kawasaki shock syndrome, and toxic shock syndrome alike. This study looked at 286 children from 53 different clinical sites in the European cities. The median age for this study was noted to be 8.4 years. 65% of the patients either had a current or previous SARS coronavirus infection. Once again, more than 96% of these patients presented with fever, and gastrointestinal findings once again was predominant. They presented once again with Kawasaki-like symptoms with rash, conjunctival infection, oral mucosa involvement, and this reveals that 40% of patients presented with shock, 26%, 0.7 with coronary artery dilation. And in this study, they only revealed one death. When we look at our Caribbean data, we note that 9 patients in the Caribbean since border reopenings has revealed that there have been 9 cases of children with multisystem inflammatory syndrome. Of this number, 3 of these cases are actually from the Bahamas. Recent data from the Ministry of Health revealed that when we looked at our pediatric statistics, in the month of September, there was noted to be 130 cases between the ages of 0 to 19 years. In the month of October, there was noted to be 99 cases between 0 to 18 years. And when we looked at the month of November, there were 18 cases between 0 to 18 years. A multidisciplinary task force was created by the American College of Rheumatology using available evidence to provide guidance and management of multisystem inflammatory syndrome associated with SARS coronavirus and hyperinflation in COVID-19. This task force was composed of 9 pediatric rheumatologists, 2 adult rheumatologists, 2 pediatric cardiologists, 2 pediatric infectious disease specialists, and 1 pediatric critical care physician. This pathway looked at how we could diagnose these patients that may have presented. So the questions that you wanted to ask: 1, on presentation, does this child have a fever greater than 38 degrees Celsius? Is there any epidemiological link to coronavirus? Is there positive testing for SARS coronavirus, either through PCR, or was there positivity in this child's serology? Or was there some close contact with a confirmed or suspected COVID-19 in the past 4 weeks? Other questions you would want to ask are their clinical features suggestive? As we know, these features would include Kawasaki-like disease symptoms, such as mucocutaneous involvement. Other things may be gastrointestinal involvement, rash, or any other neurological impairment. Children with fever and epidemiological links to SARS coronavirus should be definitely evaluated. Alternative diagnosis that could explain the patient's clinical presentation should also be explored. Now, when we look at the American College of Rheumatology guidelines, they actually divided their guidelines in tiers. So in the diagnostic approach, patients without life-threatening manifestations should perform an initial screening evaluation based on the Tier 1 guidelines. If mild cases have abnormal results or change in clinical presentation, then they should move on to Tier 2 and be treated as moderate to severe. The overwhelming majority of multisystem inflammatory syndrome cases reported in the literature display elevations in inflammatory markers, particularly in the CRP levels. So even though our initial investigation should be limited, you definitely want to do some form of SARS coronavirus testing, whether that's through RT-PCR testing or antibody testing. You'd want to start with a CBC and differential to look for the evidence of leukopenia. You'd also want to look at your inflammatory markers, such as your CRP and your ESR. And you'd want to look at your electrolytes to look for BUN and creatinine, because some of these patients also presented with oliguria, or some of these patients presented with prerenal azotemia. If any of your results are abnormal or there's a change in clinical status, you must become concerned. If your white blood cell count is less than 1,000, if platelets are less than 150,000, if your sodium is less than 135 millimoles of liter, or if the patient presents with neutropenia or hypoalbuminemia. If your patient has mild symptoms, outpatient management with close follow-up can be rendered. This patient should be followed up in 24 to 48 hours to ensure that there are no worsening of symptoms. If, however, the patient presents in moderate to severe symptoms, this patient must be immediately admitted and inpatient management started. Concerns you'd want to evaluate for are if the patient has presenting in respiratory distress, is this patient in hypotension or shock, are there neurological deficits or altered mental status, is there evidence of acute kidney injury or hepatic injury, or if there's markedly elevated inflammatory markers or cardiac enzyme, such as your troponin. When we move to the Tier 2 part of the guideline, these patients are usually more ill, usually hypotensive, and requiring additional support. This now requires more complex testing that typically requires additional time to complete. In addition to our basic investigations, LDH, a coagulation profile, D-dimer, fibrinogen, troponin, cytokine panels, and the request for an ECG and 2D echo should be considered. Also, considerations should be the request for a chest x-ray. Cardiac evaluation is thought to be very vital in patients that present with multisystem inflammatory syndrome. A 12-lead ECG and a 2D echo is recommended for all patients suspected with multisystem inflammatory syndrome, even if their COVID screen is negative, but their features are still in keeping with multisystem inflammatory syndrome. Also, concerns are patients that may present with shock should have a 2D echo performed. This study that looked at 25 cases where 19 of the patients had echoes showed that 8 out of 19 of the patients had some significant impairment in the ventricular function, with some patients presenting with less than 28%, and 5 of 19 of these patients presented with dilated coronaries or aneurysms. So cardiac laboratory values at the time of diagnosis, specifically levels of troponin T, could be significant in determining the relative degree of cardiac involvement. The CDC has released an evaluation and management profile where it indicates that supportive measures should include fluid resuscitation, inotropic support, respiratory support, and in severe cases, ECMO if needed. They have endorsed the use of IVIG, intravenous immunoglobulin, and steroids, in addition to aspirin, antibiotics, and thrombotic prophylaxis as used in R3 patients. At present, there are no studies comparing efficacy of treatment options. The American Academy of Pediatrics and the American College of Rheumatology have published guidelines on managing pediatric patients, which we are presently discussing. So when we look to the approach in management, for starters, because these patients may have an acute but likely a post-inflammatory process, you still should ensure that appropriate PPEs are worn. We should at all times practice contact droplet and airborne precautions as indicated. Supportive management should include the use of fluids judiciously. Empiric antibiotics should be commenced, and we should ensure that we immediately take bloods for investigations. We should ensure that we contact our pediatric intensivists, the cardiologist, the infectious disease, and any other specialty team that may help with the management of our patient is crucial. What we must all be aware of is that deterioration can be rapid and retrieval time will be dependent on the clinical situation at hand. The timing of our investigations may be dependent on the clinical status of the patient. We should ensure at all times that we're monitoring vital signs, including continuous saturations, ECG with BP monitoring. As early as possible, and as indicated, a 12-lead ECG and echocardiography should be requested. In addition, we should look for multisystem involvement involving the liver, renal, or neurological symptoms. All cases with suspected myocardial involvement, especially those presenting with elevated troponin levels or ECG changes or echo abnormalities, should have early cardiology input. Imaging is of utmost importance because with echo and ECG, our concerns could include if this patient has a myocarditis, is there a presentation of valvulitis, is there a pericardial infusion, or some coronary artery dilation. In our chest X-ray, some patients may present with COVID pneumonias, and they may have findings of patchy symmetrical infiltrates or pleural effusion. If our patient presents with significant abdominal findings, our concern should be whether this patient may have a colitis, an ileitis, lymphadenopathy, ascites, or hepatosplenomegaly. We should monitor closely for signs of worsening respiratory or cardiovascular resuscitation deterioration. We should monitor for clinical signs of worsening inflammation whilst we ensure that we're giving fluid resuscitation, giving inotropic support as needed, respiratory support as needed, and in severe cases, dialysis if needed, and in specialized tertiary centers, ECMO. If our patient presents in shock, acute respiratory distress syndrome, or has significant derangements in laboratory investigations, we should consider the use of immunomodular therapy. Supportive therapy should be considered, and it's of paramount importance. Empiric antibiotics should be commenced to treat likely pathogens that may cause systemic acute respiratory infections, and we should ensure that this is started immediately. Supplemental oxygen therapy should be given to any patient that presents in respiratory distress, any patient that's hypoxemic or in shock. Our target oxygen saturation should be greater than 94%, and concerns that we should have is if the patient presents with severe respiratory distress, or if the patient presents with central cyanosis, shock, coma, or convulsions, or there's obstructed or absent breathing. In our younger pediatric population, the use of nasal prongs or cannulas may be preferred as young children tend to tolerate these better. We must emphasize the presentation of shock. We as clinicians should be able to recognize septic shock in children with any hypotension. This would be defined in the pediatric population as a systolic blood pressure less than the 5th percentile or greater than 2 standard deviations below normal for age. A rule of thumb in our pediatric grouping is any patient that presents with hypotension, we look at their age times 2 plus 70. So if you had a 10-year-old patient that presented and his blood pressure systolically was less than 90 based on 70 plus 2 times 10 for age, we know that this patient is hypotensive and we need to ensure immediate fluid resuscitation. Other concerns would be if the patient presents with altered mental status, if the patient is bradycardic or tachycardic, or if this patient has a prolonged caprophyll, if the patient has febrile pulses, if the patient is tachypnic, is mottled or has cold skin, or if this patient is hypothermic or hypothermic. We must be concerned. And after initial fluid loads with boluses starting at 20 mils per kg and reassessing after the first bolus, and if our child is still in shock, we should give another bolus at 20 mils per kg over 15 to 20 minutes, and this can be repeated to a max fluid over 1 hour at 60 mils per kg. However, if our patient is not responding to our fluid resuscitation, we must definitely consider the starting of inotropic or vasopressor support. Goals of treatment in multisystem inflammatory syndrome involve stabilizing our patients with life-threatening manifestations such as shock and to prevent long-term sequelae, which, as we know, can include coronary artery aneurysms, myocardial fibrosis and scarring, and fixed cardiac conduction abnormalities. A stepwise approach to immunomodulatory treatment in multisystem inflammatory syndrome is recommended, with the use of intravenous immunoglobulin and or glucocorticoids considered as first-tier agents. Both IVIG and glucocorticoids, either alone or in combination, are the most commonly used immunomodulatory medications reported to date. Cardiac function and fluid status should be assessed in multisystem inflammatory syndrome before IVIG is administered. In patients who are refractory to IVIG and glucocorticoids, second-line treatment can involve the use of anakinra. At this present time, there are no studies, and so we have insufficient data available to compare the efficacy of IVIG and glucocorticoids in multisystem inflammatory syndrome alone. Antiplatelet or anticoagulation therapy should be initiated based on patient's risk assessment and presentation. Low-dose aspirin should be used for patients who exhibit signs and symptoms of Kawasaki-like syndrome, or if their initial platelet count is greater than 450,000. Aspirin, however, should be held and avoided in patients that may be thrombocytopenic or who have a platelet count less than 80,000. Anti-acid treatments should be used to prevent gastrointestinal complications in patients with multisystem inflammatory syndrome because we are placing these patients both on steroids, sometimes high dose, and aspirin. Enoxaparin is recommended as an anticoagulant therapy for patients with multisystem inflammatory syndrome or patients who have had moderate or severe left ventricular dysfunction. In addition, this should be used if the patient has the presence of coronary artery aneurysms, or if the echo confirmed an ejection fraction less than 35%, or there's documented thrombosis, or if the patient has more than mild left ventricular dysfunction. This increases their risk for intracardiac thrombosis. Children with multisystem inflammatory syndrome will need close clinical follow-up, with cardiology recommending that a repeat echocardiogram be performed 7 to 14 days after initial presentation, and then 4 to 6 weeks, and this should be guided by the cardiologist. Patients that may present with left ventricular hypertrophy or coronary artery aneurysms require more frequent echo evaluations and closer follow-up. Studies have indicated that a cardiac MRI should occur 2 to 6 months for patients who have had significant left ventricular dysfunction or an ejection fraction less than 50%. As we all are aware, COVID-19 is new. So the long-term effects on the heart are still unknown, and daily studies are occurring. Multisystem inflammatory syndrome is a reportable disease entity. The World Health Organization has a case definition and case reporting forms that should be utilized in keeping with other countries in the region of the Americas and across the world to allow for comparability. Our cases should be reported to the surveillance unit of the Ministry of Health. And in addition, all of our cases and our COVID cases are being reported to the Caribbean data site so we can compile all of our data for patients presenting in both the pediatric and adult patients in the Caribbean. So in summary, thank you for allowing the Department of Pediatrics to review and summarize the clinical presentation of this new childhood disease that is most likely linked to SARS coronavirus infection. Multisystem inflammatory syndrome is a dangerous systemic infection characterized by extreme inflammation, fever, abdominal symptom, conjunctivitis, and rash. Children will typically show signs and symptoms of multisystem inflammatory syndrome 3 to 4 weeks after coronavirus infection, and many will progress rapidly into shock and cardiorespiratory failure. Overall, children will survive this hyperinflammatory condition with the administration of IVIG, steroids, and the inclusion of a multidisciplinary team to ensure that prompt recognition occurs. Once we can identify earlier patients with multisystem inflammatory syndrome, then most children will survive, like our 3 cases that we presented today. But the long-term outcomes from this condition are presently unknown. So in conclusion, sadly, as we deal with the impacts of COVID-19 on every level, from the effects to the economy, to health, to families, and the education of our children, we as pediatricians have seen an influx in the fall off of routine immunizations, a decline in the follow-up of our patients with chronic illnesses, an increased admission for sexual and physical abuse in our children. Patients are now presenting with increased depression, anxiety, and other mental illnesses, and sadly, even suicide. Our hopes, however, are that with 2021 on the horizon and the implementation of a new COVID vaccine, we will hopefully all begin to see brighter days. So on behalf of the pediatric department, I would like to thank our hardworking pediatric team, which includes our doctors, nurses, all of our support staff, for ensuring that our patients are managed and taken care of. I'd also like to say a special thank you to Dr. Samantha Cartwright, one of our pediatric residents, who was instrumental in helping with this presentation. I'd also like to say thank you to Dr. Tracy Gilbert, pediatric consultant Jamaica, who provided Caribbean statistics and also assisted with guidelines and management of our patients. I'd also like to say a special thank you to Dr. Cecilia Christie, our professor in pediatric infectious disease at the University of West Indies, Jamaica, who also presented multisystem inflammatory syndrome, and to Dr. Glenice Johnson, our epidemiologist at the Ministry of Health, who was able to provide us with the latest statistical data in relation to our pediatric patients. Thank you for listening, and thank you to the CME department for allowing the pediatric team to present on the final CME of the year. Thank you.
Thank you very much, Dr. Saunders, for that excellent review and presentation of recommendations and guidelines. So Dr. Jerome Lightbourne would like to say very comprehensive. The Bahamas has found its regional expert. And so with that being said, we will move on to the questions. So good morning, everyone, and thank you, Dr. Saunders, for a detailed and well-organized presentation. My questions are from a surveillance or reporting perspective. When were these cases reported at a national level, and to whom was the report given? I believe you may have already said that in your presentation, but go ahead.
Yeah, so our cases were reported to the surveillance unit at the Ministry of Health. And so they were given the data on when the patients presented, what laboratory investigations were done, the results of the SARS-CoV testing, and surveillance then followed our patients. Our first patient, who was 15 months, he was transferred from Nagua with his mother, and his mother, who had to remain because he was a pediatric patient, was not tested until after discharge. Unfortunately, her coronavirus test came back positive. And so she had to remain in Nassau for an additional 2 weeks, but all of our cases are reported to the Ministry of Health Surveillance Unit. And in addition, we also in the Caribbean are collecting data, and that's also being referred to a unit at the University of the West Indies where they are collating all of the data. And that is then sent to the World Health Organization.
Okay, so we have lots of congratulations, excellent presentation, awesome presentation. And I am thinking that this question that says specifically who was the information given to goes back to reporting in terms of surveillance.
Yes. So that's, they want to know who exactly we spoke to?
Yes. Do you have that information? If not,
I don't have that information, but I know our first case was referred to Shaman Williams, who was one of the surveillance directors, and she was informed. And so she was aware and had been given the data through Ministry of Health.
Okay.
The other two cases, I cannot confirm, but I know our initial MISC case was given to the Ministry of Health through the surveillance department to Shaman Williams, and she was the person who received the initial information.
Okay, thank you. And our next question, how infectious are patients with MISC?
So because these patients present technically 3 to 4 weeks after positive SARS coronavirus testing, they are likely not infectious, but our first two cases, their SARS coronavirus testing was positive, and so we still had to be sure that we took precautions, but studies have revealed that pediatric patients are not as infective as adult patients, but studies are still out on that because this is a late presentation. And so usually it's 3 to 4 weeks after they've been exposed to the virus. And as we know, CDC guidelines have revealed that 10 days after a positive SARS coronavirus, you are less likely infective. So we cannot confirm when exactly these patients may have become infected with the SARS coronavirus.
Okay, and again, a lot of congratulations, kudos, excellent presentation. Our next question is, have any of our kids presented with psychiatric manifestations?
So presently, I would say yes and no. Our third case, which was our 10-year-old patient, after admission, he did have an episode where he was noted to have hallucinations and delusions. But the question is whether that was related to encephalopathy, related to multisystem inflammatory syndrome, or was it a result of the high dose steroids that he had received? His symptoms were very acute and didn't last for more than 24 to 48 hours and resolved. And so to say that it was directly as relate of because of multisystem inflammatory syndrome, we could not give 100% confirmation. But yes, there are patients that in other studies may have presented with some psychiatric manifestations.
Okay, and our next question, how do our pediatric outcomes compare to other pediatric populations?
So when we look at our pediatric outcomes, I would say kudos to the Bahamas because we've had no deaths so far in our pediatric population. When we compare data in Jamaica, they've had 2 deaths. Their initial first case was a 4-year-old who presented with cerebral palsy with fever. It was not confirmed because, as we know, at the time, multisystem inflammatory syndrome was still novel and case definitions were not defined. And so they've had 2 deaths in kids less than 19. When we compare ourselves to the US and the UK, they have higher numbers, of course, because of their population, and they've had a significant number of deaths. And so I would say that our pediatric outcomes so far have been great.
Okay, and I don't see any more questions in the chat. If there are any more questions, you can post them in the chat. And while we wait to see if there are any final questions, I'll just ask you for some comments. I noticed when you presented, you said that it was a little bit shocking to see that 50% of the cases here in the Bahamas were obese. And you also highlighted that patients with sickle cell disease were higher risk. So with those 2 things in mind, do you have any comments in terms of concerns for the future now as we approach the winter season in terms of obesity and sickle cell disease in the Bahamas?
Okay, so just a correction. So the 50% wasn't our data, that was actually the US and the UK. But if we were to extrapolate our pediatric population, we have a significant number of children with obesity. And so it becomes concerning because studies have revealed that the adipose tissues have increased SARS coronavirus receptor binding sites. And so if these patients are exposed to some form or some reasoning with coronavirus and 4 weeks later, they may present with multisystem inflammatory syndrome. So we have to be on alert, especially with the reopening of schools, ensuring that there's social distancing, because we as Bahamians know that obesity is a major concern. And if that's a high risk factor, then it means that long-term we may see more cases. Now, as we move into the winter, that is also of a concern because that's now an increase in our flu season. And so with sickle cell patients, the weather in itself causes a concern because, as you know, they would present with painful crisis. Painful crisis could then lead to acute chest syndrome, lead to hypoxia. And so we would also want to keep these kids safe because they're already at risk for having immunodeficiency. And so it increases their complications for having concerns with coronavirus. And so we as pediatricians, we are vigilant and concerned because not just MIS-C, but the other complications related to coronavirus.
Okay, thank you, Dr. Saunders. And Dr. Bartlett would like to just let us know and let you know, always proud of our pediatric team here in the Bahamas. We are blessed to have you all. Continue your great work. We appreciate your sacrifices. And Dr. Latina Fitzgerald, excellent presentation. In your reading, did you see anything on delay in IVIG administration and outcome?
So in my reading, I did not see any evidence that indicated that we should delay. The only in reading, they indicated delay if the patient was still in shock. You'd want to delay to ensure that you had corrected shock. But in reading, it indicated that even without positivity of SARS COVID testing, and that would be both through the RT-PCR or through antibody testing, if this patient smells like MSIC or presented with mucocutaneous changes like Kawasaki, you did not want to delay treatment. You would want to treat that patient right away because, as we know, based on the literature, these patients can have rapid decline, deterioration, and death. And so you would not want to delay IVIG administration if you are concerned that this is multisystem inflammatory syndrome, because our outcome would be death with delay once a patient has corrected from shock.
Thank you. And your colleague, Dr. Yashika Seymour, her mic is unmuted. She wanted to make some comments. Dr. Seymour, you can go ahead, but introduce
Really
yourself to the
grateful.
audience
Yes.
so they know
Both
who you
Dr. Seymour and Dr. Lightburn was both supposed to make commentaries at the end of the presentation. So we can start with Dr. Seymour and then Dr. Lightburn. I just wanted to answer a quick question. Philip Swan indicated that we had mentioned the number of positive cases. He asked for the numbers of admitted children with COVID-19. We did indicate we had 10. We had 10 patients that were admitted with COVID-19 over the time period from September to present. And Dr. Seymour can go ahead.
Hi, good morning, everyone. I am Dr. Seymour, the pediatric ICU doctor. I just wanted to start off by congratulating Dr. Ferguson-Saunders on an excellent presentation, very detailed. Just a few comments I wanted to make with regards to the cases that we had and some of the challenges that we had here in the Bahamas. Yes, MISC is something where we're seeing more of it. We have a lot of information. Sorry, it's asking me to start my video so everyone sees. For some reason, it's not coming up, but in any event, I'll continue. I think most people know me. So, right, some of the challenges we had, I will tell you during this whole experience, when it comes to COVID, I have a lot of respect for the virus for two reasons. One, because it is a very serious virus that is able to cause a whole spectrum of illnesses. So even in the case of our 3 patients, the first case actually was kind of mild. And so the challenges that we had with that one was basically where to host the child, where to have the child during the illness. But we were lucky in that he was actually a mild case of MISC. He didn't require inotropes. And so his recovery was pretty quick, was pretty fast. And obviously he did well.
Go ahead. We can still hear you, Dr. Seymour.
Okay. The second case, that patient, once again, when it comes to COVID, our issue is always where do we have these children? Pediatrics is always the redheaded stepchildren. And so we ended up going into the legacy. And keep in mind, the nurses there that are volunteering, we're very grateful for them, but very few of them actually dealt with pediatric cases before. And more so, very few of them dealt with giving IVIG. We tend to give it in a very slow, graduated fashion. And so that was a big challenge for us. Even in addition, it was a challenge with regards to just examining the patient. So very careful with obeying the protocol, always being able to get them. The third patient, though, I thought was the most interesting patient because this one did not have a positive PCR. He had the positive antibody test. And so after a lot of discussion and a lot of research and debate, he actually ended up in ICU. So once again, just to reiterate what Dr. Ferguson-Saunders said, when the patient has MISC, they are not expected to be infectious. And so for him who had a negative PCR, but a positive antibody test, he was actually able to be housed on in the ICU. So, I mean, I just overall wanted to say these patients were actually very, very sick, particularly the second 2. And so once again, we have to be very vigilant with our diagnosis and keep in mind too, that even if you're trying to find out whether or not or determine whether or not it's MISC versus Kawasaki, the treatment is still IVIG. So we actually recommend giving the IVIG as soon as possible because what we're trying to prevent is the development of those aneurysms, which our third patient actually did develop, but luckily with his repeat echo, it showed that they had gotten smaller. The other thing that I just quickly want to mention with regards to the COVID is the second reason why I respect this virus so much is because of its ability to make us forget other infections, other diseases. So we have to be vigilant and remember, yes, we respect the virus for what it can do, but we also have to remember that there are other diseases that can happen and we need to make sure we treat them all in a timely fashion. But once again, thank you, Dr. Ferguson-Saunders. It was an excellent, excellent presentation.
Thank you very much, Dr. Seymour. But before you leave us, there is a question in the chat. How accessible is IVIG in our setting?
So for us, we're actually, the pharmacy always has it in stock. I can't think of a time where it was not in stock. The only limitation is whether or not you're asking for it at midnight versus asking for it at 9 o'clock in the morning. But we have definitely been able to get the IVIG within hours of its need.
Okay, thank you very much, Dr. Seymour. And I believe Dr. Lightbourne wanted to make some comments as well. Is Dr. Lightbourne still on the chat? And while we wait for Dr. Lightbourne and to unmute him, there is one more question, Dr. Saunders. Would a child with HIV be a greater risk? And are there any studies in the African population for comparison?
So I did not come across any studies in the African population with relation to coronavirus and multisystem inflammatory syndrome. So in terms of the child with HIV though, I would say that it depends on the staging, because as we know, there are different stages of HIV. And if this child is severely immunocompromised, meaning if this kid has a significant viral load, if this kid has a significantly low CD4, then this kid is more immunocompromised. And so I am sure that this kid would likely have more symptoms and be more symptomatic, but I've not seen any studies per se that actually gave that comparison, but I'm hoping in the near future, we do see studies coming from that area so we can get a better understanding of this evolving syndrome that's changing daily and amazing us every week.
Okay, well, thank you very much. I do not see any further questions for Dr. Saunders. I am not seeing Dr. Lightbourne. I am not certain that he's still on the chat with us. What you can do, Dr. Saunders, is you can try and reach out to him. And in the meantime, I will just do some housekeeping announcements.
So I did try to call, but he's not answering. So I'm not sure he probably already.
Hello.
He's
hi, Dr. Lightbourne. Good morning.
Good morning.
Good morning. I know you don't need an introduction. Everyone on the chat knows who you are, but just in case there's someone on the chat who does not know who you are, please introduce yourself and we welcome your comments.
Well, hold on a minute. Hold on a minute. No. Hey, you caught me in the store.
I am very sorry. I hope you're
No, Jerome Lightbourne, I'm pediatric cardiologist. Past PMH, still consulting into PMH. I think most people know I am. What do you need from me?
We wanted you to make some comments. Dr. Saunders mentioned you wanted to make some comments at the end of the presentation on the multisystem inflammatory syndrome.
Well, I heard I kind of commented on my chat already. I think we have found a regional expert, Dr. Saunders. I'll give her kudos for that. She's done an extremely incredible presentation. I heard what Dr. Seymour had to say as well. And I echo what she said in that this is a disease that has to be respected like Kawasaki. And we are fortunate in the Bahamas, as you also stated, we have a great cadre of pediatricians that are attuned to this and kind of step in very early and refer very early and intervene very early. That's why our results from Kawasaki disease and our results from MASC remain so good. When first coming home, when first coming home, we had severe Kawasaki disease, people died, people got ischemic limbs. Now with the cadre pediatricians and I guess well-trained, we don't see that and we intervene early. But with respect to MASC, I think everything had to be said was said already. It is a disease entity that must be respected. Fortunately for children, they do extremely well. There have been deaths, as Juana said. The limitation and the stress I have is the lack of immediate access to the imaging in the Prince of Margaret Hospital. And if anything should be sent from this message in this talk, is that those cases who present in shock and those cases who present very ill, the recommendation is that they do have, can you hear me?
Yes, we can, Dr. Lightbourne. Go ahead.
Those cases who present in shock, and those 34% of cases that present with Kawasaki need immediate echo and echo every 2 to 3 days, especially if they have cardiac compromise, and most of them do. The issue with the institution is we don't seem to be able to get that. So patients are delayed getting those imaging. I want us to fight. So hopefully administration is on this line and they will be able to see the need for that and hopefully push for it. The issue, despite that though, our results I think are very good. Testing, and we don't seem to have an issue in the hospital with getting the troponin and the BNP, which I think all is very important to help with the ischemic issue, but also to follow up. I think we are in tune to MISC. We're going to see more and more of it. I think the issue with the Black and Hispanic population is not that they are at more risk of it, just that we see COVID more in that population. So needless to say, you expect to then see more MISC in that population. And so that's in the Bahamas. Sorry, let me get my vehicle. So that's in the Bahamas. We kind of expect the similar thing with the risk population. So the more risk of being exposed to COVID, you higher risk of getting MISC. Sorry, everyone. So MISC for me is a disease to be respected. I think Dr. Saunders did a very good job. MISC though, the spectrum of disease does not have to be severe, as she stated. So it depends which classification you use. I think we probably have more MISC than we actually saying we see. We have 3 cases in Doctor's Hospital who don't really meet our criteria, but they were COVID positive. Put those in the study. So Deshaun, thank you very much. I think you are a regional expert, and I think we should refer to you for information in the future. Any questions?
So if there are any questions that pop up in the chat, Dr. Lightbourne, we will let you know, or I will send you a message. But at present, there are not any questions in the chat.
Okay, very good.
So have a good day.
Sorry, I'm driving.
Okay,
good day,
be safe.
Okay, thank you.
So thank you, everyone. Do you have any final comments before we close off, Dr. Saunders?
So once again, even though I presented the case, it's a team effort. And so that's more than anything I want to stress. And once again, Department of Pediatrics, every arm. So it's like the human body, the arms, the head, the feet. Every person played a role in the successful treatment of these patients. And we want to just say thanks. And thanks again to the CME department for giving us this opportunity to share our cases. Thank you, and everybody have a good day, and Merry Christmas, Happy New Year.
Okay, well, thank you very much, Dr. Saunders. And thank you for presenting this excellent review to us and telling us, what we should be looking for and how to move forward with our pediatric population. And so to our audience, this brings our CME presentations for 2020 to a close. So thank you very much for your participation during the year. We have to date presented a total of 15 CMEs. 13 of the CMEs that have been presented are already ready with certificates. So if you have done your evaluations, your certificates are ready. And the last 2 presentations, which will be the presentation by Dr. Roper and the one today by Dr. Saunders, will be ready by the end of the month. If you would like to present, you can contact me, you can private message me, and I will get in touch with you and we can arrange a presentation. We do not plan to start back CMEs again until March of 2020. Again, the enrollment key for this presentation is PEDS COVID, all lowercase, PEDS COVID, and the feedback address is in the chat box. A very, very big thank you to Dr. Darren Halliday, who has run these meetings for us with all his IT skills, putting us on YouTube and video archiving our CME program. So for those of you who may have colleagues that have not been able to attend, the CME program is available online. You can look at the meetings and claim CMEs for the last 12 meetings. The code is embedded in the CME presentation. So to all of you, have a very safe and a very Merry Christmas, and we will see you in March of 2021. And thank you mostly to all of you for being such an excellent audience and for your participation.